Hello, ladies and gentlemen. Welcome to Triple N Media. I am Dr. Nik Nikam, a cardiologist from Houston, Texas. The cardiology seminars are brought to you by Triple N Media. Our YouTube channel has more than 200 cardiology related lectures for medicine, internal medicine board, for cardiology fellows, and for nurses. Please do watch them and please do subscribe to our YouTube channel. The featured presentation. I also have a cardiology rotation manual which has close to 175 to 180 pages of useful information to make your cardiology rotations much more enriching. I'll tell you at the end of this presentation how you can get a copy of the cardiology rotations manual for free. The feature presentation is Introduction to 2D Echocardiography, Echocardiogram Views and Structures. I have done echocardiogram for more than 35 years. I bought an echo machine back in 1982, so you don't have to guess my age. And I have been doing echocardiograms. The last machine I had was, of course, GE Dimension, Vivid Dimension 8. So I'm going to walk you through different planes in which we take the images and what structures we are looking at and how to get various views besides the regular 2 or 3 views that are routinely mentioned. So let us begin with the main feature presentation. And here's an echocardiogram machine. As you can see, we have a big monitor here. Then we have a control monitor where we can touch screen to change various parameters, and here are the various dials to input patient information. And we can do 2D echocardiography, we can do pulse Doppler echocardiography, we can do continuous wave Doppler. We can also study the blood vessels using a different transducer, where we can put the transducer here to do the carotid ultrasound test, which I used to do in my office. And this is how you place the patient in the left lateral position and you use the transducer. This is like looking from the apical 4-chamber view. As you can see, this may be a 3-chamber view or 4-chamber view. We can see, and I'm going to walk you through each one of them, and all these images can be saved as loops. So let's begin with the orientation of the heart. Inside the chest, the heart is sitting like this. As I say, the apex is like this, the heart is sitting like this, just a little bit to the right side. So we use this one as the longitudinal axis plane, and this is the longitudinal axis plane. Then this is the short axis, where we're taking the short slices of the heart as we go from the base all the way to the apex. And then this is the 4-chamber view, where we take an image from the tip of the heart and put the transducer horizontally, so it is going through the heart this way, so that we can look at the right heart, the left heart, the right atrium, the left atrium, and many other structures. So here, to kind of summarize from a different perspective, here we have the parasternal long axis, then we have the parasternal short axis, which goes like this way. We have the apical 4-chamber view, which fans like this. And we also have a subcostal view to look at the right ventricle, the inferior vena cava, the superior vena cava, and the right atrium. And from the suprasternal notch, we can use what is called the period-off pulse to look for the aortic flow and also to assess the aortic stenosis murmur. So this is the basic views. These are the basic views that we generally use to obtain an echocardiogram. So let us begin with the first one, parasternal long axis, which is going from the apex to the right shoulder. And the transducer is sitting like this, and it is slicing through the heart, and this is what we see. Here is the chest wall, here we have the right ventricular cavity, here we have the aorta, and this is the aortic leaflet, this is the interventricular septum. This is the anterior leaflet of the mitral valve. This is the posterior leaflet of the mitral valve. And this is the left atrium. And here we have the descending thoracic aorta. And behind that is the epicardium. And here we have the posterior papillary muscle. So this represents the infralateral wall of the left ventricle. As we can see, this is the left atrium. And anything that accumulates behind the aorta is pleural effusion, and anything that is, we see a coronary sinus here also, anything that is in line with the coronary sinus and inside the pericardium is the pericardial fluid. So these are some of the basic structures. Of course, we look for calcification of the valves, valve misfunction, and mitral valve prolapse can be detected here. Now we'll go to the next image, which is a parasternal short axis that is slicing the heart like this at different levels. You can just take like a knife and just slicing it through from the atrium level all the way down to the tip of the heart. And this is at the papillary muscle level, and we can see the left ventricular outline here. This is the septum. This is the anterior wall. This is the inferior wall or inframedial, inferolateral. This is the lateral wall, and these are the papillary muscles. This is the left ventricular cavity. And as we go towards the apex, the cavity becomes smaller and the muscle thickness increases because we are coming towards the apex of the heart. And here's the anterolateral papillary muscle, and here we have the posteromedial papillary muscle. And the first view we saw was going through like this, which is through the septum and through the infralateral wall of the left ventricle. That was the parasternal long axis, which we saw here. Okay, the third image is apical four chambers view. So this is going like this one, fanning through the entire width of the heart, like from this end to this end, and this is going from the apex. The transducer is here. Now the transducer, the closest part is the apex of the ventricles, and here we have the left ventricle recognized by the thick muscle and the distinct papillary muscles, and to the right we have the right ventricle. Here is the tricuspid valve, here's the right atrium, and here we have the left atrium. More often we see some defect here, but that doesn't mean everybody has atrial septal defect. I will show you where we can see this a little better and actually measure the flow in the subcostal view. These are the mitral leaflets. So this is the anterior leaflets because this is the anterior wall. So here's the anterior leaflet and here is the posterior leaflet, and these are the chordae tendineae attaching to the papillary muscles. Here's the left atrium, and you can also see the pulmonary veins draining into the left atrium. Now let's move to the next one, which is the subcostal view. That is, we take the transducer and put it just underneath the subxiphoid process and press it a little bit firmly so that we can get good contact and fan it towards the left side of the heart so that we can see the right ventricle, which is the closest one. We have the interventricular septum, and behind that we have the left ventricular wall, posterior wall. And here's the papillary muscle, chordae tendineae, mitral leaflet, left atrium, and right ventricle. Here we may be able to appreciate the presence of atrial septal defect, and when we put Doppler, we can see the color flow Doppler moving back and forth between the two chambers if there is a shunt between the right atrium and the left atrium. Of course, all of these are tagged with the electrocardiogram so that we can precisely time the blood flow, the Doppler velocities, and also valve movements. And that's the liver there. And now inferior vena cava. When we are doing the subcostal, we fan towards the apex of the heart to get the subcostal view. If we fan towards the midline and a little bit to the left side, the transducer like this way, instead of doing this way, you just turn it this way. Now we can see the right atrium, we can see the inferior vena cava. And when we check for the inferior vena cava, we look at the size of the inferior vena cava. We ask patients to take deep breath and sniff to see if the inferior vena cava collapses. If the inferior vena cava does not collapse more than 50%, we may be dealing with a patient with volume overload, cardiac tamponade, or constrictive pericarditis, and a whole host of conditions that interferes with the flow of blood from the vena cava into the right atrium. Here we may also see some of these eustachian valves and Chiari network besides other structures. And here's the hepatic vein. Now this is the right ventricular inflow view. While we were doing the the apical fourth chamber view, we can move this towards the right side. So instead of going this way, we can move it a little bit to the right side. Then we can see the right ventricle and the right atrium along with the superior and the inferior vena cava. A lot of these views are routinely not done unless we are suspecting right heart pathology. And this is the right ventricular outflow tract, which is often done, and this is with the transducer in this view. We can see here we have the left ventricle, here we have the right ventricle, and here's the pulmonic valve, and here's the pulmonary artery. Here we'll be able to appreciate the pulmonic stenosis or pulmonary regurgitation murmur, and we can also put Doppler and measure pulmonary flow and velocities. This is the apical fourth chamber view. Just in the previous couple of slides, I talked about the apical fourth chamber view, and that was involving the left ventricle, right atrium, left atrium, all these things. But when this transducer, which is going this way through the chambers, if we just lift it up a little bit, now we are going to come in contact with the aorta. So aorta will be in the plane. In that way we can see right ventricle, right atrium, left atrium. They're sort of foreshortened, but now we get a very clear picture of the aorta, the outflow tract, and the aortic leaflets. This is a great view because this is parallel to the transducer. We can get excellent recording of the aortic valve gradient, and we can also look for aortic regurgitation. Then we look for wall motion abnormalities. We can also measure the left ventricular outflow tract for calculating the aortic valve area. And of course, here is the mitral leaflet. This is a parasternal short axis at the aortic valve level. As I said, we put the transducer like this crosswise, and we can go span it all the way from the base all the way to the apex. This is right where the aortic leaflets are seen. Here we have the right ventricular outflow tract, and here's this aorta, and this is the Mercedes-Benz sign of the aortic leaflet. We have this is the right coronary cusp, and this is the left coronary cusp, and this is the non-coronary cusp. How do we know that's what I'm telling you? Well, it's fairly simple, because the front one close to the right ventricular outflow tract is the right coronary cusp. The one on the left side is the left coronary cusp, unless some institutions they flip the image. In that case it will be different. And here we have the left atrium, so obviously the one which is close to the left atrium is going to be the left coronary cusp. And on the right side we have the right atrium, and this is the right atrium, so this is the non-coronary cusp. We can look at the aorta, we can look for any abscesses or dissection, blood flow through the lumen of the aorta. We can also look for aortic regurgitation with pulse Doppler. Then we'll see sort of a mosaic pattern here that will help us to recognize the aortic regurgitation. And this is a two-chamber view. When we were looking at a parasternal long axis, we were looking at three chambers: the left atrium, left ventricle, and the aorta. But when we turn it just a little bit to the left, away from the aorta, then we're going to see just the left ventricle here and the mitral valve. A great way to look for mitral valve leaflets, particularly mitral valve prolapse, and also look at the left atrial size. So this is the two-chamber view where we focus upon the left ventricle and the mitral valve and the left atrium. This is the parasternal short axis at the mitral valve level. Now we are coming towards the mid part of the heart, like somewhere here. The first part was this one. Now we are coming towards the mid part of the heart, where we see a fish mouth like mitral leaflets. Here is the thick round ventricular muscle, which is approximately 1.1 to 1.5 centimeters or 1.3 centimeters. Here's the right ventricle, and here's the right ventricular wall. We may not clearly see the right ventricular wall all the time. And here is the pericardium. we see the mitral valve, and if we go further down, we will see the papillary muscles also. This is the apical 3-chamber view, which is most commonly used when we start off. Here we have the left ventricle, we have the left atrium, and here is the aorta and the aortic leaflet. Here we measure the left ventricular outflow tract when we are trying to calculate the aortic valve area. Usually the mitral aortic leaflets are very thin. They just look like lines opening and closing during the cardiac cycle. The mitral leaflets, they look like sails. They are kind of wobbling between the cardiac cycles. And here's the left atrium. Okay, this is a suprasternal notch. That is, we take a special probe, which is like a small rounded one with a long stick. It's called the PEDOF pulse. We put that right here in the suprasternal notch and direct it towards the aorta. And here is the aortic arch. We can see the ascending and the descending thoracic aorta. We can put the color Doppler to look for the blood flow direction. Also, we can put a continuous pulse Doppler and measure the gradient across the aortic valve to get a much more accurate assessment of the gradient across the aortic valve, since we are in direct line with the flow of blood. And this is the suprasternal notch, and here they are using the color Doppler to look for the direction of the blood flow. Here, in case we have a patient with a patent ductus arteriosus, we can see the blood coming into the aorta and then filling up the patent ductus arteriosus and the pulmonary circuit. So this is a crash course rundown on various echocardiographic windows and basic cardiac structures. So I hope this introduction has been useful to you. So when you are making rounds in the hospital, when your cardiology fellow or an attending is showing something, at least you have seen something like that before on this presentation, so you will be able to relate them to the various structures and planes. And then we take all these 30 or 40 or 70 images we do and come up with a composite report. Echocardiogram is a pretty time-consuming, tedious process. It takes 45 minutes, an hour to do a study, especially if you're dealing with valvular heart disease or some congenital abnormalities. You may spend hours getting good quality images. Then you have to process those images, compile them together, and come up with a composite report. Echocardiography is exceedingly useful in diagnosing the structure of the heart, the size of the heart, the ventricular function, wall motion abnormalities, hemodynamics, pressures, compliance, and a lot more. We can even measure cardiac shunts and evidence of fluid, tamponade, you name it. Echocardiography is a very, very essential study in the field of cardiology when we are evaluating patients with coronary artery disease or structural heart disease. Please do subscribe to our YouTube channel and watch more than 200 cardiology lectures we have on our YouTube channel. As you can see, we're covering most of the cardiology book. Heart murmurs, changes during various maneuvers, heart inspection, palpation, starting with basic foundation of history, physical exam, jugular venous pressure, carotid pulse, arterial pulse, many other topics. Oh, if you want to get a copy of my cardiology rotations manual, you can send me an email to doctor, that is drnikam @gmail.com. Actually, the email is in the description below. And this has been a presentation of a Triple N Media. I will see you in the next presentation. Please do subscribe to our YouTube channel.